Hello everyone, my name is Sarita Rawat. I am Assistant Professor in School of Pharmacy, Suresh Gyan, Vihar University. Today we will start our next lecture, that is Pharmacology of Expectorant and Antitussive. So this is in your unit first, pharmacological. So content of today's lecture, we will cover all these topics. We will start with the introductory part of cough. What is the cause behind coughing? What is the cough reflex? What are the cough receptors? What are the mechanical event in cough that involved in coughing? What are the drugs that are used in cough? What are antitussive and what are expectorant and their activities? So learning outcomes of this module is you are able to know about the drugs that are used in cough, what are the mechanisms behind that, and what are the adverse effects, what are the toxicities, what are the dosage forms that are used in coughing, and you are able to know the treatment of coughing. So firstly, what is cough? How cough happens? Everyone knows about cough, I guess. So, cough is an essential protective function for human airway and lungs. Cough reflex involve a highly orchestrated series of involuntary muscular action with potential for input from the cortical pathway as well. So mainly the productive cough is happen when anything stuck in your respiratory tract. So it is like a defense mechanism, we can say. Cough is productive reflux, its purpose being expulsions of respiratory secretion or foreign particles from the lungs and upper airway passage. Cough may be useful, that is known as productive cough, and sputum is coughed up, drain the airway, or useless cough, that is non-productive cough and dry cough. So these are some organ related disease and what are their clinical features. So in the organ that related in pharynx, we have a post nasal drip. Common cause is post nasal drip, and the clinical feature is history of chronic rhinitis. Then in the larynx, we have a rhinitis, tremor, whooping cough, and cough. So because of that, person may face voice of swelling, altered has of painful cough, and paroxysma of cough, and often associated with stridor. Then in trachea, tracheitis happen. So now the clinical feature of that is raw retrosternal pain with coughing. Then in bronchi, bronchitis, acute and COPD. So what happen in this? They dry or productive or worse cough in morning. Then in asthma, usually dry and worst cough at night. Then eosinophil, in this feature similar to the asthma. So usually dry or worse at night coughing. Then bronchitis, no airway hyperreactivity. And then bronchial persistence often with the hemocytis, as in or carcinoma. Then we have a lung parenchyma. So in this part, there are lots of severe disease occur like tuberculosis. So in tuberculosis, productive often with hemophysis. Hemophysis is mainly when the blood come into the coughing sputum. Then pneumonia, dry, irritability, productive, later productive. Changes in the posture include sputum production. Pneumonia and bronchitis, the same problem. Then the pulmonary edema, often at night, may be productive of pink for the sputum. Then in the intestinal fibrosis, dry and irritant and distressing cough happen. Then there are some drugs also that may can cause coughing. So the adverse effect of the drug is coughing. So which include ACE inhibitors. So ACE inhibitors often cause side effect of dry coughing. Now coming to the point, types of cough. How many types of cough is there? So when we classified them according to the duration, according to the characteristics and quality and time. So we found that there, according to the time, we have a acute cough. So in acute cough, there is a sudden onset. It starts with a sudden onset and it lasts long for 3 weeks. Then we have a subacute cough. Subacute cough is it goes to 3 to 8 weeks. Then we have a chronic cough. So in chronic cough, what happens? It is more larger than the duration of the coughing is more than 8 weeks. Then, what is the mechanism behind coughing? So, when we see the mechanism, stimulation of chemoreceptor that are present in throat, respiratory passage, or stretch receptor in lungs, they send afferent impulse to the cough center that are located in medulla, and then the efferent impulse by parasympathetic and motonerval to the diaphragm, then the intracortical muscles and lungs, and they send the increased contraction of diaphragmatic, abdominal and intracortical, that is your ribs muscles, noisy explosion. So that when happen the coughing. So this is the whole mechanism behind coughing. What is drug used for cough? So mainly we follow the symptomatic treatment. As I say, cough is a symptom, not a very serious disease. So we follow always a symptomatic treatment for coughing. Or whenever any person is suffering from any severe disease and the symptoms come out as a cough, so we have to use the symptomatic treatment for that coughing. So for that we use mainly a specific remedies and specific therapies. What is cough reflex? Now, rhinax, trachea, carnea, bronchi, terminal bronchioles, alveoli that are sensitive to foreign matter and corrosive chemical stimuli. So, what happened? Afferent nerve impulse send respiratory through the respiratory passes and vagus nerve go to the medulla of the brain. Whenever any foreign particles, foreign metals, or chemical stimuli enter into the respiratory system, our afferent nerve impulse started to send message through a vagus nerve in the brain, medulla in the brain. Then the afferent pathway, central pathway, and efferent pathway involved in this mechanism. So afferent pathway, how afferent pathway involved? So sensory nerve fibers located in the ciliate epithelium of upper airway and cardiac and esophageal branches of the diaphragm. So they involve in the cough reflex. Then in central pathway, there is a upper brainstem, that is the pons part. Then if when we talk about the efferent pathway, so how it involved in cough reflex. So impulse from the cough center through vagus, phrenic, spinal motor nerve to the diaphragm, and then it's go to the abnormal wall of the muscles. Then nucleus retroamygdalus, it goes through the phrenic, spinal motor nerve and inspiratory and expiratory muscles. Then the nucleus amblygus go through the lineal branches of the vagus and then linex. So this all process involved in the efferent pathway of cough reflux. Then termination of vagal afferent. but then termination of vagal afferent cause evident in the ear mucosa from upper airway to terminal bronchioles of the lung parenchyma. So, three broad classes of afferent nerves are involved in the cough reflex. The first one is rapidly abducting receptor that we call RAR. Then second, we have a slowly adapting stretch receptor that we call SARS. Then we have a C fibrosis also. So when we talk about the rapidly adapting receptor, it is a dynamic receptor that responds to changes in the mechanical property, then sporadically active throughout the respiratory cycle. Its activation involves stimuli evoking bronchospasm obstruction resulting from the mucus secretion or edema. Then histamine, capsaicin substance, and substance P and bradykinin also activate this receptor. Then stimuli evoking cough. Now coming to the slowly adapting stretch receptor, how they activate, what are they and how they activate? They are highly sensitive to the mechanical forces put on the lungs during breathing, and they are actively increased during inspiration, peak just prior to the inhalation of the expiration, and they are active through central inhalation of cholinergic drive to the airway, decrease panic nerves activity, and decrease airway smooth muscle tone. Now, when we talk about the C fibrosis, so what is C fibrosis? Majority of afferent nerve in inverting airway and lungs are unmelanated C fibrosis. So PGE2, adenylene, adenosine, and cysteine bradykinin synthesis C fibrosis, and they are activated by increased airway parasympathetic nerve activity and the chemoreflex characterized by apnea, bradycardia, and hypotension. So this is all about your C fibrosis. Now, what is the mechanical event of cough? What are the events that involve in coughing? So, first is inspiratory phase. So, inspiratory phase is involved inhalation, genetics, the volume necessary for cough effective coughing, and compression phase. That next come to the compression phase. What happen in this phase? Closure of larynx combined with the contraction of muscles of the chest wall, diaphragm, and abdominal wall, and which may increase in the inthoracic pressure. So expiratory mechanical phase, what happen in this? This glottis opens and which leads to high expiratory airflow and which leads to coughing. And large airway compression occur, high flow occur due to this dislocate muscles from the airway and allow removal from the tracheobronchial tree. So this is your cough phasing, as you can see in this image. This is the irritation, then inspiration, then compression and explosion. So how the whole coughing process, what are its phases there is already seen in this picture. So you can clearly see it. Now, pharmacology of coughing. So, what are the drugs used for cough? So, mainly antidepressive and expectorant are the drugs that are used to cure coughing. Expectorant are more accurately known as bronchomucotropic agent, and they are drugs used to assist and the removal of secretion or exudate from the trachea, bronchi, or lungs. So they act by liquefying viscous muscle or mucopurulent exudates that is, they are decongestants and therefore they are used in the treatment of cough and to help expel these exudates and secretion. Antitussive are the agent that especially inhibit or suppress the act of coughing. So they should not to be used to suppress productive coughing, and expectorant and antitussive are the most commonly used in the symptomatic treatment of common cold and bronchitis. So as I already told you, we use anti-cough medicine for symptomatic relief of another disease, because cough is just a symptom of the another disease. Then drug for cough. So we have a pharyngeal demulcent that includes lozenges, cough drops, linctures containing syrup and glycerin. Then we have a expectorant. Expectorant, we have bronchial secretion inhalers, sodium potassium citrate, potassium iodide, guaifenesin, ammonium chloride. Then we have a mucolytics, also mucolytics that break down the mucus. We have a bromohexane, ambroxol, acetylcysteine. Then the another class we have antitussive, that are cough center suppressants. So they mostly work on the CNS. Then they include opioids, which include codeine, phoscodine, and ethylmorphine. Then we have a non-opioid. We have a noscapine, dextromethorphan. Then we have antihistamine. Antihistamine include chlorpheniramine maleate and diphenhydramine and promethazine. Then when we talk about the expectorant, the introduction in detail. So expectorant are mainly expectorant are oral drugs that are increased bronchial secretion or reduced its viscosity, then facilitating its removal by coughing. Simply they enhance the clearance of mucus, also called mucokinetics. Okay, so we can also call expectorant as a mucokinetics because they expel out the mucus. Then FDA has removed most expectorant from the market in a review of over-the-counter drug. So only you can get them by prescription form. Only guaifenesin is approved as expectorant in the US as a OTC drug. Then when we see the classification of expectorant, we find out the following class. First one is our bronchial secretion enhancer. So it includes sodium or potassium citrate, potassium iodide, guaifenesin, glycerol glycol, bismuth tolu that we and vasaka, ammonium chloride. Then we have a mucolytic. Mucolytic we have X bromohexane, ambroxol, acetylcysteine, and carboxetine. Okay, so these are the bronchial secretion inhaler and mucolytics. Now coming to the point, bronchial secretion inhaler enhancer. We have a potassium iodide secreted by bronchial gland and can irritate the airway mucosa, and they are considered to increase bronchial secretion by salt action if potassium iodide given externally for prolonged use so affect thyroid function and produce iodism. So we do not have to use it for a long time because it can cause thyroidism. Then guaifenesin, vasaka, tolu balsam are the plant product enhance bronchial secretion and mucociliary function. Ammonium salt are nusating and they are reflexly increase respiratory secretion. So US FDA has stopped marketing of all expectorant except guaifenesin because they are causing a nauseating effect. Okay, so nowadays steam inhalation or proper hydration may more helpful in clearing the airway mucus. Then, when we talk about the mucolytics, so we have a several agent can reduce the viscosity of sputum in vitro, but clinical study in chronic bronchitis, asthma, and bronchitis not showing much activity. So mucolytic drugs that include X derivatives of cysteine reduce the disfluid bridges that bind glycoprotein to other proteins such as albumin and secretol IgA. So these drugs also act as antioxidant and may therefore reduce airway inflammation. So only an acetylcysteine, that is mucomyst, that is its brand name, and other is available in the US. Carbocysteine, methylcysteine, aldocysteine, or bromohexine are available everywhere. So now, COPD patient, if not treated with inhaled corticosteroid or other medication, so symptomatic relief after the treatment with carbocysteine. So we can use it in COPD patient when they are not responding to the corticosteroid. But an acetylcysteine is not currently recommended for COPD management. Various triggers like oxidative stress, cigarette smoke, inflammatory cytokinin, and activated TLRS stimulants, the epidermal growth factors (EGFR) receptor, which play a critical role in the airway mucus secretion from goblet cells and submucosal gland. So, small module inhibitor of EGFR kinase such as gafitinib and allotinib, anti-cancer drug, are currently used for the treatment of mucus hypersecretion in COPD patient. Now these are the drugs that involved in the coughing. Bromohexine, ambroxol, and acetylcysteine, carboxysteine. So these are our expectorant. The use is a derivative of bromohexine used as a potent mucolytic and mucokinetic. It depolymerizes the mucopolysaccharide directly, as well as labeling lysosomal enzymes and network of the fibers in tenacious sputum is broken. So the dosing for this is adult dosing. You can use it in 8 mg TGS, and children we can use it in 1 to 5 year 4 mg BD, and 5 to 10 year 4 mg TDS. The side effect of bromohexine include rhinorrhea and lacrimation, nausea, gastroirritation, and hypersensitivity reactions. So we have also other drug like ambroxol metabolite of bromohexine, having similar mucolytic action, use and side effect. Then we have it is similar than the bromohexine, but the dosing is different. We can use it in 15 to 30 mg TDS, and then ambibrolite is the brand of this drug. So you can see it clearly. Then when coming to the antitussive, we have what is antitussive now? Antitussive, these are the drugs that acts in the CNS to raise the threshold of cough center or act peripherally in the respiratory tract to reduce tussle impulse or both these actions. So, actually cough is a common symptom of airway disease, but its mechanism are poorly understood. So, very vital infections of the upper respiratory tract are the most common cause of cough. And post-viral cough is usually self-limiting and commonly patient-mediated, and antitussive should be used only for dry non-productive cough, or if cough is usually disturbs sleep or is hazardous like hernia, piles, cardiac disease, occurs surgery, ocular surgery, so we can use the dry cough. For dry cough we can use antitussive. So before treatment with antitussive, it is important to identify the underlying cause and mechanism that may require therapy. So whenever we want to take any antitussive or expectorant or any drug for the treatment of coughing, so we have to know about the reason why the cough is happening. If the patient is having which particular disease, what condition they are suffering from, so according to that we take the cough medicine. Now we have classified antitussive in different categories. First is opioid. So opioid include codeine, ethyl morphine, flucodeine. Then we have a non-opioid. Non-opioid we have nascaffine, dextromethorphan, clofendrol. Then we have a antihistamine. Antihistamine we have a chlorpheniramine, diphenhydramine, and promethazine. Then we have a peripherally acting. We have a brenoxidine. Then we have a exuvant antitussive that we also call bronchodilator. We have a salbutamol and terbutaline. So coming to in detail, first is our opioid derivative. So what is opioid derivative? That are opiates have a central mechanism of action on mu receptor, mu opioid receptor in the medullary cuff center, and they may have additional peripheral action on cuff receptor in the proximal airway. So codeine and folcodeine are commonly used derivative in the post-viral cough, but they produce side effects like sedation and constipation. So whenever any person is suffering from viral, so they are having a symptom like coughing, so they can use codeine and flucodeine. This is only a prescribed drug due to its another abuse use, so you can use it for post viral coughing. Then it may also cause side effect like sedation and constipation. So morphine and methadone are effective but indicated only for intractable cough associated with the bronchial carcinoma. So this is only prescribed in bronchial carcinoma. So now you can see here codeine, ethyl morphine, and its use, its dose. So when we talk about the codeine, it is an opium alkaloid, less potent than morphine, but is more selective for cough center. Codeine is standard antitussive, suppress cough for about 6 hours, and the antitussive action is blocked by naloxone indicating that it is exerted. So through opioid receptor in the brain, the side effects include low abuse, liability, and constipation. At higher dose, especially in children, respiratory depression may occur and drowsiness can occur. So the dosing of codeine in children is 2 to 6 year, and 2 to 6 year is 2.5 to 5 mg, and for 5 to 10 years it's 5 to 10 mg and used as a syrup codeine phosphate, and that is come into 4 to 8 ml, and the brand name is codeine 15. Then we have a ethyl morphine. It is closely related to codeine and which is methyl morphine and has a antitussive respiratory depressant properties like it, but it believes to be less constipating. So when we compare it with the when we compare it with codeine, so it has less side effect than the codeine. So it come in the form in the dosing of 16 mg tablet. Then we have a full codeine. Full codeine is it has a particularly no analgesic or editing property, but it is similar in the efficacy as antitussive to codeine and is long acting also. So it acts for 12 hours and the dose includes 10 to 15 mg. Then we have a non-opioid derivatives. Non-opioid derivatives are these are the agent used in reducing cough without causing any hallucination or narcotic action. It less abuse potential. So we have Nescaffeine or narcotine. So it is used. It is an opium alkaloid of the benzoisoquinoline series, and it depresses cough but has no narcotic, analgesic, or dependency including properties. So it is nearly equipotent to the antitussive as codeine, especially useful in the spasmodic cough, and its side effect is there also like headache and nausea, but it can relate histamine produce bronchocontraction in the asthmatic, so it is not suitable for the asthmatic patient. The dose related to noscafin is dosing 15 to 30 mg in children, commonly dosed, and in children of age 2 to 6 year we can use it in 7 to 5 mg, and in children 6 to 12 year we can use it in 15 mg. Then we have a Coscopin 7 mg per 5 ml syrup and Costco tab 25 mg tablet. So this is the brand name. You can go to buy it. Then we have a dextromethorphan. Dextromethorphan is a non-opioid, so a systematic central and methyl D aspartate receptor agonist. So also antagonize opioid receptor. The side effect is dizziness, nausea, drowsiness, and when it takes in the higher dosing, it can cause hallucination, and it can also cause ataxia. When we see the dosing of dextromethorphan, so the dosing include 10 to 20 mg and varies in children. Then we have a clofindrol. Clofindrol is it is a centrally acting antitussive which show onset and longer duration of action. So side effect include dryness of the mouth, vertigo, and irritability. Dosing for this is 20 to 40 mg. Then coming to the next point, we have antihistamines. So what are antihistamines? Mainly H1 antihistamine have been conventionally added to antitussive expectorant formulation. They relieve cough due to their sedative and anticholinergic action but lack sensitivity for the cough center. They have no expectorant property and mainly even reduce secretion by anticholinergic action. So they have been specially prompt for coughing in respiratory allergy states and through their lack of efficacy in the anti-asthmatic condition. So it include chlorpheniramine 2 to 5 mg and diphenhydramine 15 to 25 mg and promethazine that in 15 to 25 mg. Then we have a second generation antihistamines also like phenoxyphenidine and loratadine or many others. They are also ineffective. Then we have a peripherally acting antitussive. So peripherally antitussive, we have a prenoxidine is a contrast to other antitussive, and it acts peripherally and desensitize the pulmonary stretch receptor and reduce tussle impulse originating in the lungs, and it is indicated in the cuff of bronchial organ, and efficacy is however not important. Its efficacy is not impressive when we compared it with another antitussive. Then we have a bronchodilators. Bronchodilators are bronchospasmic and induced or aggravate cough, and its stimulation of pulmonary receptor can trigger both cough and bronchoconstriction, especially in individual with the bronchial hyperreactivity. So bronchodilator relieve cough in such individual and improve the effectiveness of cough in clearing secretion by increasing surface velocity of airflow during the act of coughing. Fixed dose combination of a centrally acting antitussive with a bronchodilator or with an antihistamine activity having high atropic activity. So these are some bronchodilators. Ethylene expectorant that in so these are some combination antitussive and expectorant combination that we can use for coughing to enhance its effect. So first we have ethylene expectorant, which includes salbutamol 2 and guafencin 100 mg per 10 ml. It comes in the form of syrup. Then we have a ascorbyl, so C, xylene, and we have that comes in the syrup form. Then we have a bronchosolvine that which include guafencin 100 mg plus terbutaline 2.5 mg plus bromohexine 8 mg and 8 mg per 10 ml. So they are come in the form of suspension. Then we have a Benadryl also. This is very like a known antitussive expectorant combination and mostly OTC drug used. So it include diphenhydramine 14 mg plus ammonium chloride 138 mg plus sodium citrate 57 mg plus methanol 1.1 mg per 5 ml. So it comes in the form of syrup. Then we have another drug also in the combination, like we have a Celestine. Celestine comes in the combination of carbinoxamine 4 mg plus ammonium chloride 240 mg plus sodium citrate 240 mg per 10 ml. So it comes in the form of syrup. Then we have a glinitis also. It is very like well known, we can say. So it include dextromethorphan 5 mg, chlorpheniramine 2.5 mg, guafencin 50 mg, and ammonium chloride 60 mg. Then we have another drug also. We have in a tablet form also. So solving expectorant, it comes in the tablet form. So we have that includes bromohexine 4 mg and pseudoephedrine 30 mg that comes in the form of tablet. So these are our expectorant and antitussive combination. You can see it, and you can some of them are easily available in the OTC drug, but some are only available within the prescription of any physician. Then we have concluded with some quiz also, like you can answer this very easily by going through the previous slides. The questions are included like what are the two type of coughing, like you already know about the productive cough and dry cough, uh, non-productive and productive cough. Okay. So, what are the two centrally acting antitussive in that you can easily answer because we have already go through the long list of antitussive. Then, what does peripherally acting drugs do? How they work? So, we have already studied about the mechanism of the peripherally acting drug. What does antitussive how does antitussive relieve, or what does antitussive relieve? So, and what does antitussive relieve? Easily it is cough. Then what are the various adverse reaction of antitussive? So, that are clearly mentioned in your this slide. You can see it, the adverse effect, low abuse, and then we have a respiratory depression, drowsiness. So you can easily answer these questions going through these lectures because everything is mentioned here, like the see vertigo, dryness of mouth, irritability, and dizziness, nausea, ataxia. Okay. So the next question is what are opioid antitussive contraindicated with? So you can see I have already answered this question that opioid antitussive are contraindicated in the asthmatic patient and in the non-conscious patient and in children because they cause a side effect like drowsiness, they depress the CNS, so it may cause very another harmful effect to the patient also. Then, what is a drug that loosens respiratory secretion? So, you can easily answer this question. This is a mucokinetics. They break down the secretion, break down the mucus, and then make it easy to expel it out. Then, what is the reduce the thickness of respiratory secretion by direct action of the mucus? What drug can be used? Then, what are the mucolytic used to treat? Then, what are some contraindications that of mucolytic and expectorant? So, you can also answer this question. What are the contraindication for mucolytic and expectorant? They do not use, we cannot use these kind of drug for the delicate patient that are not responding. So you these are the 10 questions. You can easily answer all these questions while you go through the previous slides. Then the coming to the reference where I have taken all these informations, you can go in detail about these information while following these references. So first I have used textbook of medical physiology from Gyan 11th edition that I have. Then I have used Davison's Principle and Practice of Medicine 21st edition. Then very famous KDT Tripathi Essential of Medicinal Pharmacology, that is JP Brothers publication. So you can easily this book is very easily available, so you must have this books to know about the detail of pharmacology. Then I have also followed the clinical pharmacology basics and clinical pharmacology by the Latin Basic. Then I have also followed anatomy and neurophysiology of the cough reflex which is very good book for the multidisciplinary respiratory medicine. So you can definitely check these books for better reference, and you will get to know in the detail about the cough and treatment of cough. So this is all about today's lecture. I hope you all know, get to know about all the clarities about the cough and how we can treat coughing. Thank you for today, and we will end this lecture here.